Good evening, sir.
Good evening. Good evening.
Good evening, Dr. Vinay.
Good evening.
Good evening, sir.
So that is Kulbhushan Haldeniya. He was our MCH student in SGPGI. Now he is a faculty member in NIMS in Jaipur.
Oh, okay. Oh, there's a NIMS in Jaipur also.
Yes, yes.
Yes.
This is National Institute of Medical Science.
Medical science.
Is it an autonomous institute? Is it a private institute or a public?
So it's a private institute, sir.
Okay. So, Dr. Vinay, what is the role of the moderator and what is the role of the chairperson?
Chairperson will conduct the individual session, but I wanted you to give an overall kind of summary after each presentation and then also moderate the whole thing.
Okay.
Himanshi, is it all set? Can we start?
Yes, sir. Done.
And there are participants online?
Yes, मैं check करके बताती हूँ sir. 2 minutes.
Yeah, because it is 7, we can start. Just confirm. Yeah, I think it's streaming. I think we will start. So, good evening, everyone. Welcome to the 4th online masterclass started by Jaipur Surgical Tutorial. Jaipur Surgical Tutorial is an online educational activity which we started about 2.5 years ago at the Mahatma Gandhi Medical College and Hospital in Jaipur. And this is being coordinated by my young faculty colleague, Dr. Anand Nagar. Today, he is busy with a liver transplant, so he's not present in the session. We've already done 3 master classes on living donor liver transplant, safe cholecystectomy, and chronic pancreatitis. And this one is on acute pancreatitis. These master classes are held every last Thursday and Friday of the month, 7 to 9 p.m. India time, and they are available for everyone to join for free online. So for today's and tomorrow's masterclass, the theme is acute pancreatitis, and I requested Dr. RA Sastry, who's currently at KIMS in Hyderabad after serving for a long time at the Nizam Institute of Medical Sciences in Hyderabad, to moderate today and tomorrow's session. Over to you, Dr. Sastry, please.
Thank you, Dr. Vinay. Good evening, everybody. And of course, welcome to the 4th master class that has become so popular in such a short span of time and educative too. Today's topic is acute pancreatitis, and we have very good faculty who have wonderful experience in the management of this unpredictable disease. In fact, most of us in the faculty have been fortunate to have been a part of the evolution in the management of this unpredictable condition, mostly through our failures, and in the process of become wiser. So let's start this session. So what I'm given to understand is we'll have one chairperson, and of course there are 4 talks in this. So before I summarize, I think I'll ask Dr. VK Kapoor because his topic itself is acute pancreatitis in a nutshell. And it's good to have a bird's eye view of the disease before you get lost in the intricacies of management, the controversies, and in depth. I think it's good to have an overview, and I understand this is mainly meant for the postgraduates and the students, the residents. So, Dr. Vinay Kapoor, please, acute pancreatitis in a nutshell.
Thank you, Dr. Sastry. So I thought since there will be some MS students also joining the masterclass, it would be good to have an overview of what acute pancreatitis is before we go into the details. So very briefly, I would touch on a few basic facts about acute pancreatitis, and then we will have more discussion in detail. So students who are participating, please note down my email address, vkkapoor.india@gmail.com. If you want to know a little more about acute pancreatitis, you can always request me for some more reading material on acute pancreatitis. So I bring you greetings and regards from the Mahatma Gandhi Medical College and Hospital in Jaipur in Rajasthan in India. And acute pancreatitis, the presentation is as an acute upper abdomen. That means the patient presents with sudden onset, usually moderate to severe upper abdominal pain, upper mid-abdominal pain. And you may think of any other organ involvement or any other diagnosis, for example, peptic ulcer, especially peptic ulcer perforation. You may think of mesenteric vascular accident. You may think of proximal small bowel obstruction. You may think of an inflammatory condition in the liver. We know that many a time biliary colic may be perceived by the patient in the mid-abdomen, upper abdomen, rather than right upper abdomen. So we may think of any other possible differential diagnosis, but in any and every patient who presents with sudden onset, moderate to severe acute upper abdominal pain, mid-abdominal pain, mid-upper abdominal pain, we should keep acute pancreatitis as one of the differential diagnoses. And to illustrate my point, I show this CT scan, which is a young lady in whom the clinical diagnosis was acute pancreatitis. But when a CT scan was done to evaluate the acute pancreatitis, it was found that it was a thrombus in the superior mesenteric vein, what is seen as a filling defect here pointed by the arrow, which was being misdiagnosed as acute pancreatitis. So both ways it is possible that it is something else and clinical diagnosis is acute pancreatitis, or vice versa. Now, once we think of acute pancreatitis based on clinical presentation, which is, as I said, is sudden onset, moderate to severe acute mid-upper abdominal pain, usually associated with retching, nausea, and vomiting, then we have to investigate. And the specific investigations would be serum amylase and lipase if they are elevated more than 3 times the normal of your lab. An initial ultrasound, which obviously will look at other organs also, for example, the gallbladder, the liver, if there is any free air or free fluid in the abdomen, and if it is combined with Doppler, it can even look at the vessels. And in some cases, a CT with IV contrast. I will discuss the role and timing of CT a little later. But in all these patients who present with acute severe upper mid-abdominal pain, we must always remember and keep in mind the supradiaphragmatic, that is cardiac and respiratory causes of what is perceived by the patient as abdominal pain, but the origin is actually in the chest, and therefore a chest X-ray, an abdominal X-ray to look for any evidence of acute intestinal obstruction, and an ECG. And whenever we ask for a chest X-ray in an acute abdomen, you have to remember that you should make the patient sit up, if not stand, at least for a couple of minutes, and then do a chest X-ray, including both domes of diaphragm. And then you would see what is seen here, the free air, especially very well seen under the right dome of diaphragm, because on the left side, you could have a dilated fundus of the stomach with air and the colon, which is full of air, and the small amount of air is better appreciated under the right dome of diaphragm. Now, CT scan for acute pancreatitis or for evaluation of any pancreatic pathology ideally should be a pancreatic protocol CT, which includes usually a no or a negative oral contrast rather than positive oral contrast, a large volume of contrast injected at a high speed, which is done with an infusion pump. Images are taken at various time intervals to coincide with the early and late arterial phase, portal venous phase, and then delayed phase, and preferably thin, even 2 to 3 millimeter slice multi-detector CT if the equipment is available. Now, it's important that for the diagnosis of acute pancreatitis, CT is not essential, because based on any two of the clinical, biochemical, or ultrasound criteria, a diagnosis can be made. The role of CT scan is more to evaluate the severity of the acute pancreatitis, which is usually manifested in the form of either necrosis of the parenchyma, peripancreatic necrosis, or local complications. And that is why it is recommended to be done not at the time of initial presentation of the attack, but after a few days. Minimum 3, some people would say 5, and some units even practice as late as 7 days, so that the necrosis, if it has to show, becomes evident and becomes evident in its full form. The only situation where an early CT scan at the time of presentation of the patient would be indicated if the clinical diagnosis is in doubt, when we don't want to miss a surgical problem like mesenteric ischemia, like proximal obstruction, like an aortic aneurysm-related problem. In that case, an early CT scan is mainly to rule out a possible surgical cause or any other differential diagnosis. Or if there is a suspicion of an early complication in the form of either bleeding or a ischemic gangrene of a adjacent viscus like colon, proximal jejunum, which is causing features of peritonitis. But if you do a CT scan very early, you would only see some peripancreatic edema, as is seen here. You may see irregular outline of the pancreas and some peripancreatic fat stranding. So CT scan, early CT scan is not mandatory for the diagnosis of acute pancreatitis. It is therefore usually done after a few days of the onset of attack. Now, once we have made a diagnosis of acute pancreatitis, the next important step is to assess the severity of the attack. And this can be done by clinical and lab parameters, which suggest organ failure, morphological changes, which are seen on CT scan, which means a pancreatic necrosis, either more than 1/3 of the organ volume or more than 3 centimeters in size. There are several CT severity indices, including the Balthazar, and presence of local complications in the form of a fluid collection, cyst, necrosis, or abscess, depending on the duration of the episode of acute pancreatitis. There are some single parameters like CRP and procalcitonin, and there are several complicated scores like Ranson and Apache, which are used, but they are not very practical for day-to-day use, especially the Ranson and Apache. They are more used when you are doing some kind of a study or a research protocol where you want to objectively compare between groups of patients. Now, organ failure is an indication of severity of acute pancreatitis, and the organs which commonly fail are, in order of importance, respiratory, where PO2 is less than 60, creatinine more than 2 milligram, cardiovascular in the form of hypotension, and significant GI bleed. To diagnose necrosis, as I mentioned earlier, you need a good contrast-enhanced CT scan. And why is it important? So once we know that it is severe acute pancreatitis based on organ failure, then it is important to find out whether there is necrosis or not. Because presence or absence of necrosis makes a huge difference in the outcome of the patient. In the presence of necrosis, the morbidity is high. Majority or almost all these patients will have one complication or the other, and mortality increases tremendously as compared to those patients who do not have necrosis, even if based on organ failure, they have or they may have severe acute pancreatitis. So on the left CT scan, we see normal enhancing homogeneous parenchyma. On the right side, we see patchy enhancement, and most of the parenchyma is not enhancing, which suggests necrosis. As I said, to evaluate the full extent of necrosis, CT should not be done too early in the illness. It should preferably be done after 3, 5, or some groups would say even 7 days. Now, once we know that there is necrosis, the next important issue is to find out whether it is infected or not. And the risk of infection increases with the amount of necrosis in terms of percentage of parenchyma, which is not enhancing, and the duration of necrosis or the duration of episode of acute pancreatitis. And this is important because if the necrosis is infected, the mortality is almost double. And it was thought earlier that in presence of infected necrosis, if we don't intervene, then the mortality is almost 100%. But now we know that there are some exceptions to this dictum. Now, the gold standard to diagnose infection was image-guided fine needle aspiration and subjecting that fluid to gram staining and culture. But more and more groups do not do that for 2 reasons. One, because it could be false negative. And second, it itself could introduce infection in a sterile necrosis. And therefore, more and more groups rely on other parameters to diagnose or suspect infection, which are indirect indicators. Now, clinical features of fever, leukocytosis, etc., are not necessarily indicator of infection in acute pancreatitis because they could be present as a part of systemic inflammatory response syndrome, which is usually seen in patients with acute pancreatitis. But organ failure, which is persisting beyond first week, is usually a good indirect indicator of infection of the necrosis. Presence of air in the necrosis on CT scan is an indication of infection, and a lot of reports suggest that a high procalcitonin is also an indirect indicator of infection of necrosis. Now, based on various evaluations, the acute pancreatitis earlier was classified as mild and severe, but in between a group of moderately severe acute pancreatitis has been suggested. And in fact, one of the classification classifies pancreatitis into 4 groups. The next talk is going to cover this in more detail, but briefly, this is determined by presence or absence of local complications, including necrosis, and then whether it is sterile or infected, and systemic complications in the form of organ failure, which is either transient, that means it resolves within 48 to 72 hours with organ support, or whether it persists beyond that period. So on one end, we have no necrosis and no organ failure, which is mild acute pancreatitis. On the other extreme, we have infected necrosis and persistent organ failure, which makes it critical severe acute pancreatitis. And in between, we have moderate and severe. Now, it's important to understand the pathophysiology of acute pancreatitis if we want to manage the patients correctly. And that includes a huge amount of third space loss of fluid resulting in shock, increased intra-abdominal pressure causing even abdominal compartment syndrome, severe inflammation resulting in SIRS, translocation of gut bacteria resulting in infection of the collections and necrosis, endotoxemia, which is responsible for multiple organ failure, and over a period of time, severe catabolism leading to malnutrition. So all these things have to be kept in mind and looked after when we manage acute pancreatitis. The management of acute pancreatitis in the first 2 weeks, unless there are early complications, as I mentioned earlier, is largely medical. So it's a non-surgical disease, and it includes basically organ support. So patients with severe and maybe even moderately severe acute pancreatitis should be managed in a high dependency or intensive care unit. Their nutrition has to be looked after if possible, and as far as possible, enteral nutrition with a nasogastric or nasojejunal tube, and only in patients with severe ileus who are not tolerating any enteral nutrition, then parenteral nutrition. From vigorous fluid resuscitation, we are now coming to goal-directed fluid therapy. Role of antibiotics is very controversial. These patients have pain which needs to be looked after, and counseling of the patient and relatives regarding hospital stay, cost, and outcome, which is unpredictable, is very, very important. Organ support is mainly respiratory, inotropes, good glycemic control, renal support, acid suppression, and these patients may have hypocalcemia, which needs to be looked into. The role of antibiotics in acute pancreatitis is a very debatable, very controversial topic. There is evidence that it is not, they are not required in patients with sterile necrosis, but in practice, most groups do use prophylactic antibiotics, especially in patients who have extensive pancreatic necrosis, even if there is no suspicion of infection. And if they are used, then quinolones, piperacillin combinations, carbapenems, and they should be given at least for 14 days. There is a very controversial role of selective gut decontamination, and patients who have been in hospital for a long time, who've been on prolonged antibiotics with multiple tubes and drains, probably should receive antifungal prophylaxis. Now, the key issue in necrotizing pancreatitis is about intervention. Which patients require intervention? When should it be done? What kind of intervention? And if it is surgical, how that is to be done? So in brief, broadly speaking, the indication for intervention is if we know or we suspect that the necrosis is infected and it is causing systemic sepsis in the form of organ failure. Sterile necrosis, only if it is not responding to maximal intensive therapy over a period of time with no improvement in organ function, may be an indication for intervention. And abdominal compartment syndrome is a very debatable issue. And desperate surgery, that means when nothing else is working, your intensivist says that please operate upon the patient, is again something which is very, very controversial. Now, the standard management of necrotizing acute pancreatitis today is what is known as a step-up approach. It starts with percutaneous intervention, which in some cases could be definitive. But the most important role is to delay surgical intervention, as we would discuss, to a later period, and sometimes to handle post-surgical residual collections. There is a greater role today of endoscopic transgastric intervention using lumen opposing metal stents, which will be discussed tomorrow. And finally, surgical intervention, which could be minimally invasive or open laparotomy approach. Endoscopic intervention on the bile duct in gallstone-related acute pancreatitis, the only possible indication is severe acute pancreatitis presenting within 48 hours, or if there is cholangitis, which becomes an indication. Most meta-analyses have shown that it doesn't make any change in mortality, but probably the complications could be less. But we have to remember that this endoscopic intervention has to be done by a very, very experienced endoscopist. Surgical procedure for necrotizing pancreatitis is necrosectomy. It is not resection of pancreas. It is removal of the necrosis, which could be laparoscopic, minimally invasive, retroperitoneal, or open. The best instrument to do necrosectomy is a blunt instrument, finger or suction tip, not knife, not an energy source. And in most of these cases, one should think of a feeding jejunostomy in place of a nasojejunal tube. And in case the viability of the colon is in doubt, then a prophylactic or preventive diverting loop ileostomy. The timing of intervention, now most groups follow the dictum that you delay the surgery as far as you can using endoscopic and laparoscopic approaches, percutaneous and endoscopic approaches to buy some time, because earlier you have to operate or you operate, higher is the mortality. Surgery should definitely not be done within the first 2 weeks unless there is a complication requiring it, and preferably it should be delayed to beyond 4, and some people would say even longer than that. And one of the approaches is minimally invasive retroperitoneal approach or video assisted. And it starts with the CT-guided percutaneous drainage, and the tract is then dilated. And through that, a nephroscope or finally even a retroperitoneal open approach can be used, wherein one goes behind the transverse colon. But this is most suited for necrosis confined to the tail and distal body of the pancreas. Head of the pancreas may be difficult to handle by this approach. As I said, counseling is very, very important because by and large, patients with severe, especially infected necrotizing pancreatitis have a long hospital stay, including prolonged ICU stay. Rate of reoperation or reintervention need is very high. Costs can run very high. And in spite of all this, the mortality still remains in the range of 10 to 20%. So counseling of the patient and relatives in the beginning is very, very important. So I would like to end up by saying a patient with acute upper mid-abdomen, after excluding surgical causes with whatever investigations required, we make a diagnosis of acute pancreatitis. Next step is to assess the severity, mild, moderate, or severe. And if it is severe acute pancreatitis, we have to find out whether there is necrosis. Treatment is largely conservative and supportive. If the patient improves, fine. If doesn't, then it can be an indication for intervention, which to begin with is non-surgical. And finally, in a small proportion of cases today, surgical intervention may be required. If it is acute pancreatitis, we have to find out the cause. Usually it is stones and alcohol, but if they are not there, then further investigations to find out, especially if the patient has recurrent acute pancreatitis, and that would include biochemical evaluation, MR or EUS, and finally genetic studies. So with that, I would like to end. And students, if you want to read more about acute pancreatitis, please send me a mail, vkkapoor.india@gmail.com. Thank you. Thank you very much. Dr. Sastry, please.
Yeah, thank you, Dr. Vinay. I hope you all got the pearls of wisdom from the brief summary of acute pancreatitis, which is important. See, what if I have to further summarize? What we have learned in these 3 decades is basically, apart from the diagnosis, where it is mainly by exclusion of the surgical conditions which require urgent intervention. As a surgeon, it's important to rule out the conditions which would require urgent intervention. Second is, now we have a clear definition of what we are talking of. See, that clear definition of the terms which will be dealt in a little more detail. The third is, we're able to stratify the disease in its highly varying severity, thanks to the imaging, the organ failure scores, and the advances. So it's important to stratify it into mild acute pancreatitis, which does not require any critical care, or severe acute pancreatitis, or in between. We are also able to identify the severity is not just by the biochemical scores, but by imaging. I must emphasize here, you should be absolutely clear in your CT analysis, in identification of the spaces, the peritoneal spaces and the extraperitoneal spaces, whether there is necrosis or no necrosis, and the complications. Is there infection, or the signs of infection in terms of gas, in terms of say hollow viscous perforation, or any impending bleeds? See, these are the important things which you would see by the CT. And with all this, we are able to define the treatment strategies basically non-interventional and interventional, and the right time for an intervention. The other important thing which we have learned in these 3 decades is we have learned to intervene with the least disturbance to the complicated physiology of acute pancreatitis through minimally invasive approaches, the endoscopic, percutaneous, laparoscopic modes, and tailor our interventions through multidisciplinary care and using the best use of our local resources. Well, if I have to summarize, I think these are the important things which you would remember, and these would be dealt with in a little more detail now. I think we'll go to the topic. Dr. TD Yadav.
TD says that he has just finished the OT. He will take a few minutes. I think you can please carry on.
Okay. So we have Dr. Anand Nagar.
No, Dr. Kulbhushan will be doing.
Dr. Kulbhushan will be dealing with the definitions, the nomenclature, and the current classification of acute pancreatitis, which is very important because this is what is, it would lead you to the treatment strategy and compare your results with others. Dr. Kulbhushan, please.
So before Kulbhushan starts, I would like to introduce him. Kulbhushan is my former fellow from SGPGI Lucknow. He is currently consultant GI surgeon and faculty member in surgical gastroenterology at the National Institute of Medical Sciences, NIMS, in Jaipur. Kulbhushan, please.
Yes. Good evening, respected teachers and colleagues. My topic is nomenclature and Atlanta classification of acute pancreatitis. So we cover this topic first we discuss the original Atlanta classification, then what is the issues in the original classification, then we discuss the revised Atlanta classification, and then conclusion. So okay. So Atlanta classification, it was introduced in 1992, and it provides the standardized definition for acute pancreatitis, types based on severity, guidelines for severity assessment, and definition of local complications. So definition by Atlanta classification: acute pancreatitis is acute inflammatory process of pancreas with variable involvement of other regional tissue or remote organ system associated with raised pancreatic enzymes level in blood or urine. So they define the severity in 2 types, in mild or severe acute pancreatitis. In mild acute pancreatitis, there is minimal organ dysfunction and usually uneventful recovery. And in CT scan, there is usually normal enhancement of the pancreatic parenchyma. In severe acute pancreatitis, there is associated organ failure and local complications. Local complications like necrosis, abscess, or pseudocyst. They define the organ failure and systemic complications like shock if systolic blood pressure is less than 90 mm of Hg. Respiratory complications if there's PaO2 is less than 60, and renal failure if serum creatinine is more than 2 milligram per deciliter after rehydration, and GI bleed is 500 ml blood loss in last 24 hours. And systemic complication in form of disseminated intravascular coagulation, like platelet is less than 1 lakh, fibrinogen is less than 1, and fibrin degradation product is more than 80. And severe metabolic disturbances like calcium is serum calcium is less than 7.5 milligram per deciliter. They use the severity prediction by the Ranson score and Apache score. Ranson is more than 3 and Apache second is more than 8. So they define the local complication by acute fluid collections, pancreatic necrosis, acute pseudocyst, or pancreatic abscess. So acute fluid collection there is occur early in the course of disease, and it usually located in or near the pancreas, and there is always like a wall of granulation of fibrous tissue. In pancreatic necrosis, there is a non-viable pancreatic parenchyma either diffuse or focal areas of necrosis will be visualized, and it usually associated with the peripancreatic fat necrosis. Non-enhanced pancreatic parenchyma, like sir has already told, more than 3 centimeter or involving more than 30% of the pancreas area is requisite criteria for diagnosis in the CT. Acute pseudocyst is a collection of pancreatic juice that is enclosed by the fibrous or granulation tissue, and it usually takes more than 4 weeks after the onset of symptoms, and most often it is sterile. Pancreatic abscess, this is the circumscribed intra-abdominal collection of pus, and usually this is in proximity to the pancreas and containing little or no pancreatic necrosis. So why we need the revision of this Atlanta classification? There is various loopholes, or I can say issues. Like it did not consider adequate parameters to define mild and severe pancreatitis. Second is, like in severe acute pancreatitis, if we do the subgroup analysis, there is very different outcomes even in the severe pancreatitis. Third is like forms of acute pancreatitis, necrotizing pancreatitis. This is one of the highest mortality, but it will not characterize well or inadequately described. Like they not define the sterile, infected, pancreatic, or peripancreatic, or both. Organ failure was not adequately categorized, like transient or persistent. Fifth, like often it was confusing to communicate between the professionals regarding disease progression or regression, because this is a dynamic disease and it will changes according to the intervention. Sixth one is definition did not include pathophysiology, severity, and radiological description of pancreatic and peripancreatic collections. And seventh is the description of pancreatic and peripancreatic collection is confusing, that is not universal. So because of these, the revised Atlanta classification was described. It was revised in 2012, and it enables standardized reporting, which helps for communication between clinicians and for research. Offers a comprehensive classification, severity, and peripancreatic collections. It differentiates like local complications, acute peripancreatic fluid collection, pancreatic pseudocyst, acute necrotic collections, and Waldorf necrosis. So, how they define the acute pancreatitis, in which they request two of the following three features. One is clinically, like patient had abdominal pain consistent with acute pancreatitis. We, as all know, there's the acute onset of persistent severe epigastric pain, which often radiates to back. And biochemically, when the serum, the amylase and lipase, it at least 3 times the upper limit of normal value. And there is radiological third finding, in which there is a characteristic finding on CT and less commonly in MRI or ultrasound abdomen. What are the types? There is 2 types of acute pancreatitis. One is interstitial edematous pancreatitis, and second one is acute necrotizing pancreatitis. So in interstitial edematous pancreatitis, there is acute inflammation of pancreatic parenchyma or peripancreatic tissue, but without the recognizable any necrotic necrosis. So in CT, you can see the pancreas is enhancing well, and there is pancreas is bulky, and there is also peripancreatic fat standing is visualized, but there is no area of non-enhancing, like no area of necrosis seen. In acute necrotizing pancreatitis, when the inflammation is associated with the necrosis, either is parenchymal or peripancreatic. And in CT, you can also clearly see there is at the neck or body part, there is lack of pancreatic parenchymal enhancement is visualized. Other pancreas is enhancing well. They describe the severity in 3 forms: mild, moderately severe, and severe acute pancreatitis. In mild pancreatitis, there is absence of organ failure and local or systemic complications. In moderately severe acute pancreatitis, there is transient organ failure is there with or local or systemic complications. Okay, but there is no persistent organ failure is present. Transient organ failure is like organ failure for less than 48 hours. And severe acute pancreatitis that define the persistent organ failure. So how they define the organ failure? They use the modified Marshall scoring system, in which the three organ system like respiratory, cardiovascular, and renal, and when score is 2 or more than 2, they considered the organ failure. Like in respiratory, PF ratio is less than 300. In renal, when serum creatinine is more than 1.9, and in cardiovascular, when there is systolic blood pressure is less than 90 millimeter of mercury, and that is not responding to fluid. So, what are the phases of acute pancreatitis? So, they are two overlapping phases in dynamic process, early or late. Early phase, which usually lasts for the first week, that is followed by the late phase, that is usually 4 weeks to month. So in early phase, this occur due to the host response to the local pancreatic injury, and this the pancreatic inflammation activate the cytokine cascade. This lead to the SIRS, systemic inflammatory response syndrome, and when this SIRS is persist, then it lead to the increase the risk of developing organ failure. Although local complications may be identified during the early phase, but they're not the predominant determinants of severity, because predominant determinant of severity is organ failure. And also it is unreliable to determine the extent of necrosis during the first few days of disease. So it said already, sir, like the CT is not done usually in early phase, it done after the 3 days, or few studies suggest usually 5 to 7 days is a minimum limit to do a CT scan. In late phase, when there is a persistent of systemic signs of inflammation, which lead to the organ failure, and there is local complications evolve during the late phase. So you can see like local complication, we are talking about the local complication of organ failure. So late phase occurs only in the moderately severe or severe acute pancreatitis. Come to the local complications, definition of pancreatic and peripancreatic collections. So in edematous acute interstitial edematous pancreatitis, the local complications occur in form of the acute peripancreatic fluid collections or pancreatic pseudocyst. And in acute necrotizing pancreatitis, occurs in form of the acute necrotic collections when it occur before the 4 weeks, and after the 4 weeks, when the wall is found well, then it is known as WPN, Waldo pancreatic necrosis. So take 1 to 1. In acute peripancreatic fluid collections associated with the interstitial edematous pancreatitis, and it is not associated with any peripancreatic necrosis, and peripancreatic fluid in the first 4 weeks, like before the 4 weeks. And in CT, you can see like in this film, there is peripancreatic fluid collection in this and but the pancreas is normally enhancing well. There is no necrotic areas visualized, and wall is not found well. Okay, and usually this local complication resolve itself within a few days or week. And you can see in second picture that after the few days, the pancreas is enhancing well, but there is no fluid is visualized in the CT scan. Second is acute necrotic collections. So this is a complication of acute necrotizing pancreatitis before the 4 weeks. So collection containing variable amounts of both fluid and necrosis. Okay, and necrosis can involve both parts, pancreatic or peripancreatic tissue. And CT, you can see there is a heterogeneous enhancement of pancreas with some areas of non-liquefied tissue and liquefied part, that is necrotic part. And there is also peripancreatic collection, necrosis is also seen. But in acute necrotic collection, same as the acute peripancreatic fluid collection, wall is not formed. Come to the pancreatic pseudocyst. This is when wall is formed after the 4 weeks. This is a continuity of acute pancreatic fluid collections. So it usually occurs more than 4 weeks. An encapsulated collection of fluid with a well-defined wall. Okay, usually outside the pancreas with minimal or no necrosis. So in CT, you can clearly see that there's a homogeneous fluid with no liquid component, and wall is well defined. Last is walled off pancreatic necrosis. So this is mature encapsulated collection of pancreatic or peripancreatic necrosis that developed after the complication of acute necrotizing pancreatitis, and usually it occurs after the 4 weeks. And CT scan, you can see the heterogeneous with liquid and non-liquid density part in both in this picture, and wall is well defined. And location can be like both as intrapancreatic or extrapancreatic. MRI is better to differentiate necrotic and non-necrotic tissue. Like in this fourth picture, it is clearly visualize this hypotense, the necrotic part, and this is the liquefied is hypertense and T2 weighted images. So summary, like how did this revision have an impact on clinical practice? Because it avoid the confusion in terminology seen in the original classification. It also standardizes the terminology across the specialties, which helps in treatment planning and also helps in comparison of results from different institutions. It precisely describes patient with acute pancreatitis, and it precisely describes the pancreatic collection, which is important because treatment varies with collection type. You see in the further topics. And this classification, the CT, helps guide management and monitor the treatment success. Thank you.
Yeah.
Kulbhushan, there are one or two questions in the chat which Himanshi has sent me. Himanshi is the technical support which is always provided to Jaipur Surgical Tutorial by Dr. Avinash Nath. He's another former fellow from the Department of Surgical Gastroenterology at SCPGI, currently at Dwarika Hospital in Ahmedabad. So related to what you presented, Dr. Bihar Kotecha, he's one of the senior surgeons from Tanzania. He wants to know what is the duration to call it transient versus persistent organ failure. What is the cutoff?
So it's transient when organ failure is for less than 48 hours, and persistent is more than 48 hours is persistent organ failure.
And his other question is, when do you call the disease late? I don't think there is any terminology to say late acute pancreatitis, isn't it?
No, so the phase is late, but late
Yes.
acute pancreatitis is not described.
And Dr. Jitendra Chauhan wants to know what is the type of enteral feed which should be advised to patients, volume and timings. It is the standard feed. If the patient can take orally, you give oral diet. If the patient is having nausea or is not willing to take orally, then you can do tube feeding. And most studies have shown that there is no difference between nasogastric and post-pyloric, nasoduodenal or nasojejunal feeding. The only thing practical is that if there is a retropancreatic inflammation or collection, retrogastric, some of these patients may not tolerate nasogastric. So if the patient is not tolerating nasogastric or oral feed, then it is better to pass the tube across the pylorus, preferably into the proximal jejunum. And most of these patients will tolerate nasojejunal feed. As far as the amount is concerned, as much as the patient can tolerate, and in fact, most people would say that even if patient is in ileus, small volume of enteral feed should be given because it is well tolerated, absorbed, and also it takes care of the gut immune function and prevents translocation of bacteria. So as much as the patient can comfortably tolerate, oral, nasogastric, nasoduodenal or nasojejunal feed in that order should be given. Only if the patient is not tolerating enteral feed, then one has to think in terms of parenteral nutrition. Dr. Sastry, please.
Yeah. Most of the points are mentioned. If I have to summarize, say a practical approach, now that we have diagnosed acute pancreatitis by excluding the more important surgical conditions, how do we approach this patient? The important thing is to decide whether it is a mild acute pancreatitis, moderately severe pancreatitis, or severe pancreatitis. So how do we do that? By looking for signs of organ failure or local and systemic complications. We have various ways of assessing these. A lot of scores are mentioned, but say as a practical person, you need to remember only SIRS first. See, SIRS is crucial in many areas of acute abdominal conditions, acute surgical conditions. And the organ failures, the Marshall score is the standard. You just remember Marshall score. It has only the respiratory, renal, and the circulatory components. Not very difficult to remember. You just need to know the PaO2 and FiO2 in the respiratory component, the serum creatinine in the renal component, and the hypertension and tachycardia, and whether these are fluid responsive, how long are they occurring? Are they transient or are they more than 48 hours? That is all you need to know to stratify them into mild, moderately severe, and severe acute pancreatitis. Why do you need to stratify them? Because you don't want to shift all these patients to critical care just because acute pancreatitis. If it's a mild acute pancreatitis, they would not require critical care. They can be either managed at home or they can be managed in the ward for 1 or 2 days. Because sometimes you have these transient episodes, and then you would like to keep the patient on observation. So I think that is what is now. The other thing is about the imaging. When you want to do imaging, Dr. Vinay has already mentioned, within for 72 hours, there's no point in doing a CT unless you want to rule out other surgical conditions. 72 hours to 1 week. What is the indication? All severe acute pancreatitis. And if SIRS is continuing, or whether if there are signs of concern, see, some of these may not be appearing in the organ failure scores and the SIRS. Like you have a patient with comorbidities, or you have an obese patient, more than 30 BMI, or he has lung problem, say pleural effusion and some lung infiltrates, or he has an unsettled abdomen. He has an abdominal distension with ileus. See, these are matters, signs of concern. And these are the indications where you want to do a CT for better, just to see whether there is necrosis, how much is the necrosis, and what are the areas. Is it confined to one area? Is it peripancreatic? Is it in the pancreas? Or is it in the right side, left side? These are, again, of prognostic importance. And if there are any complications like gas and the visceral perforation. I think these are the few points I wanted to re-emphasize in this. We'll go to the next one now. If there are any other comments or questions.
Sastry, can you hear me?
Yeah, I can hear you. You want to comment?
I just want to make a brief comment.
Yes,
I would let the people who are attending this meeting leave with a very simple algorithm in their mind. Let us not get into anything complicated. Simply remember, if it is acute edematous pancreatitis, it leads to an acute fluid collection and it leads to an acute pseudocyst. If you have acute necrotizing pancreatitis, it leads to an acute necrotizing collection and it leads to a walled-off necrosis. This is all that you have to remember in the algorithm of how we are. Forget organ failure, forget everything. Acute edematous pancreatitis, acute fluid collection, acute pseudocyst. Acute necrotizing pancreatitis, acute necrotizing fluid collection, and walled-off necrosis. Simple algorithm to remember the way acute pancreatitis progresses.
There is a comment by Dr. Vishal Gupta, who's watching it online. He says the current imaging-based classification systems fail to include those patients who succumb to the disease within 48 to 72 hours without giving any opportunity to have cross-sectional imaging to classify these patients into any of the existing categories. He wants some of us to comment on that, Dr. Sastry.
Yeah, see, these are unusual patients. Very unusual to have a patient dying within 48 hours if you have not identified the SIRS in that patient and, a patient who has escaped your attention or he is treated in a lesser facility, it is possible. But in a patient who is reported to you, it's unusual to find that kind of situation. If a patient has succumbed, I would rather think of other conditions than acute pancreatitis.
I would only say that these would be patients who are probably elderly, who have other comorbidities, who probably have a severe SIRS to begin with. So if such patients have features of organ failure, even if it is too early to classify them into moderate or severe, probably they should first be taken into an intensive care or high dependency unit. And as Dr. Sastry says, the death probably is because of the organ failure like respiratory, cardiac, on a pre-existing background of multiple. Otherwise, it's not very common to see a patient with severe acute pancreatitis dying within first 48 to 72 hours. But then imaging would not help, because if they have severe or multiple organ failure, they anyway should be managed in an intensive care or a high dependency unit with organ support. That is only thing which can be done at this stage.
Shall we go
I think
to the next?
we can ask Ramesh to chair the next session. Ramesh?
Yeah, I will chair it. Yeah. Who is speaking?
Yeah, TD will be.
Yeah, I will chair it. Yeah.
So maybe you can
TD Yadav,
introduce.
you are good to go. Everybody knows who is TD Yadav.
No, but still, because we have a lot of or some participants from abroad, please introduce him.
So TD Yadav is Professor of Surgical Gastroenterology at the Postgraduate Institute of Medical Education and Research at Chandigarh, one of India's most prestigious medical colleges and postgraduate teaching institutes. And he has done a lot of work on pancreatitis and on Whipples. And so I request him to take up his topic and manage it.
Sir, good evening, sir.
Yeah.
I have started sharing my slide. Is it
Am I seen? I'm not seeing it. Is it seen by the others? I have a video problem. I'm not getting any videos.
No, we can only see a white screen and a cursor moving. Just the white screen, nothing else.
Then what is this screen? Sorry, everything. This is Zoom screen only, sir. No, sorry. What is this screen? Whiteboard is Zoom, sir. It is showing that it is Zoom. Okay. I will share again, sir. Sorry. Should I log in again? It seems so.
Okay, we'll wait for you.
I don't know why this is coming.
any technical help possible? He is able to log in, but the screen is just white and the cursor is moving.
I also need technical help because I can't get my video working. So you can't see me. And then I won't be able to.
Oh, I don't know why this whiteboard is coming in this one, sir. This whiteboard is the moment I am starting Zoom, it is whiteboard is coming.
TD, I would suggest stop sharing.
Yes, sir. I stopped sharing, sir.
No, stop sharing. Then open your presentation.
Okay, sir.
First open the presentation and then share the screen.
Presentation is opened, yes, sir.
Okay. Okay. Mhm.
Oh, I think got it now. Yes, just stop sharing. Now it will come.
Yes, yes.
So there was some problem. Yeah, it seems okay, sir.
Okay, now we can see.
I would also need some help for my video to come on to the screen later after this talk.
I think in the meantime, Ramesh, please send the video to Himanshi. Maybe she can play it from there.
Yeah, I will do that. I will.
Yes.
How can I send it to him?
Send it to me. I'll forward it to her.
Okay. Okay, he can start. No,
Yes,
not
yes.
wait for me.
Yes, sir. Yeah, TD,
So,
please.
good evening and thanks, sir, for giving this opportunity. Sorry, I got little bit late. Today was war and I got stuck up. So, this is a very specific topic, sir mentioned lots of discussion on acute pancreatitis and diagnosis and of infection, and only two things I have to discuss, and how to assess the severity. So I wrote a scoring system because different scoring systems are available. Not going into lots of detail of all the literature. Based on the PG students, they are sir said only PG level PG students they should understand. So I will show some good pictures of the city, and based on which we are managing our patients. So it is very, very important to just to start that I want to emphasize that it's very important to have a good CT scan and lots of knowledge of presentation of the acute pancreatitis, as well as we should have clinical features of the this acute severe pancreatitis is very, very important. Even if we are having
TD आपका म्यूट हो गया. हाँ, unmute.
sorry, sir. There is some outside the house, some thing is going on.
Yeah. Now we can hear you. Please carry on.
There is some sound going on the road. I don't know what is that. So, so that's why I have made very simple presentation. How we diagnose this patient and what we do. Infection diagnosis is very, very important. And there are only one differential which is important in a setting of acute severe pancreatitis early. that one is some ischemic bowel with some fluid collection, and another is there may be some sort of like perforation where there is no gas under the diaphragm, and you have not done CT scan. Then sometimes there can be a differential. So it is very, very important to understand these two important features we are finding in the routine. So to how we diagnose the infection in acute severe pancreatitis. So in the beginning, it's very important to look into the clinical features. So as I just listened very small part of the earlier presentation, and very nicely it was described that early and delayed late presentations do two phases of acute severe pancreatitis. So early phase, usually it is because of the inflammatory mediators, and there is no sitting arm infection. That's why lots of controversy about starting of antibiotics in an early phase of pancreatitis. So clinical features are very, very important. And meaning thereby we should see everything, including heart rate, pulse rate, heart rate, respiratory rate, and abdominal condition of the abdomen, then blood pressure, then what is the fever. If there is a fever, then we have to look into not only pancreas, other important structures also, which are there is a systemic presentation of the acute severe pancreatitis. Then what can be done earlier when we started managing pancreatitis, and it was said that sterile pancreatic necrosis usually doesn't need any treatment. So if patient deteriorates or develops fever, then you used to aspirate, put a needle under the guidance of CT or under the guidance of ultrasound. If it is available, if it can be managed, then aspirate the fluid and send it for culture. And if there is a growth of the bacteria or even gram staining and something is coming, then you used to start antibiotics, and antibiotics also based on this thing. Otherwise, you were not starting antibiotics. So that is one way that you can aspirate what is there. If there is no fluid, then even pancreatic necrosis area can be aspirated a little bit. Second, now which is most commonly we are being done is you are going for a step-up approach, and if patient clinical situation demands, it is very, very important. Then one can have a percutaneous drainage when you put the tube, and at that time only aspirate the fluid and send it for culture. And if there is a growth of the bacteria, then it comes to we say that there is a infection. Third, very important is without having any of intervention, if we have a patient where there is a gas in the pancreas, then it is very, very relevant, very important to know that it can be either by the gas forming bacteria, or it could be by the colonic fistula or even duodenal fistula, which is both these are more common. It can be even stomach, but gastric fistulae spontaneous is very, very rare. So if you are seeing in the bed, just I will show one picture of this thing. So this is the picture where you could see that the whole pancreas is full of gas, and there was no colonic fistula. So I'm not discussing about intervention or doing or not. I'm just only want to say that if this is available, then you can say that there is infection. If you aspirate fluid from the infected area, like in necrosis, and you are getting fluid like this, then again you can say that this particular pancreatitis is infected. Or if you are putting a PCD and you are still getting this fluid and aspiration, and then you are going for a culture and sensitivity, and you are finding that there is a infection. So these are the three very important ways we can document that there is an infection. So whatever necrotizing pancreatitis is there, what we call one, whatever we call, it is now infected. So there is no I think other way by which we can diagnose. So what is the role of imaging? As I said, just I will take a little bit just to show the CT scan, because CT is the gold standard for in the management of acute severe pancreatitis. And as I said, in the excellent image for the pancreas, can assess the pancreatic necrosis. We can see the extent of the necrosis. Why I am telling this? Because in our severity assessment, it is going to come. So it can sometimes identify cholecystectomy or other causes of abdominal pain, which might be complication or which might be sometimes unrelated, and identifying the complications like acute fluid collections, pseudocyst, which is going to be formed later on, or one or any vascular complication, which can happen in acute severe pancreatitis, like pseudoaneurysm, which is common, which might bleed, which might not bleed, but if we are finding it, we have to go to manage it. So this is the CT scan. So we, based on the CT scan, we take one component is CT scan, by which we can say that this particular patient has a severe pancreatitis or it is not the severe pancreatitis, but CT is not the only thing. So I will go into part 2, which is these are some pictures. Part 2 is assessment of the severity. So we do CT scan very frequently. We sometimes repeat after 7 days. If in the progression time, as discussed earlier also, that usually 72 hours is the time when CT scan is indicated, until unless you are having some differential diagnosis problem or you are suspecting some complications of the acute severe pancreatitis, then only early CT scan might be required. Otherwise, in the beginning, only supportive care. So coming directly to the part 2 of my my talk, and that is severity assessment. So starting with we know that Ranson criteria, we know that Ranson has 2 components. One is for the stone disease, it is different little bit, and for the alcohol, it is little bit different. And it has 11 variables in it. And at the admission and after 48 hours, again you assess. But lots of drawbacks have been discussed about Ranson, because most of the patients, when they come to the hospital like tertiary care center, already that 48 hours is gone. So usually they present late. But it has been found that if your patient is of more than 55 age group, if there is obesity, which is very strong this thing, because the Apache score is also Apache O has been described in the literature to see the severity in a obese patient. So when there is organ failure at the admission and it is persisting. So suppose there is organ failure, also had somebody discussed a little bit. Organ failure has also two components. One is that how many organs are failing at the admission. Number of the failing organs at the admission, 20% increase in the mortality. Suppose there is one organ failing other than pancreas, 20%. If there is a respiratory failure, 20% add it at the admission we are talking about. And if it is persisting, then it is more significant. If it is reversed within 48 hours, after resuscitation, it means pancreatitis is going to be moderately severe. It might not be severe pancreatitis, might not need, as Dr. Sastry was talking about, might not need admission in the ICU. Then if there is a pleural effusion, as I was discussing, at the admission, this is a significant marker of the patient is going to have a severe pancreatitis in the later on, and we have to be more careful. We can admit him in the high dependency unit. We have to monitor each and every organ and give supportive care so that patient doesn't deteriorate, and be ready to get admitted in the ICU or very high dependency unit. If hematocrit, again very important, is more than 44, again it is a very important predictor of the severity, which is at the admission, then patient is going to have a severe pancreatitis. So starting with the most simple and very important predictors of the severity, to bicep score, which has come later than after Ranson. And Ranson, as all we know, that Ranson score was very popular. But then Apache came, it came for the ICU. Then it has almost replaced the Ranson because of it can be bedside assessment, it can be assessed daily. So bedside assessment, bedside index of the severity, bicep score is very popular. It is very simple, and multiple this publication are there comparing its relevance with other scores like Ranson and other Apache, and it has been found that it is equally good. It can be managed bedside, anyone can do it. So it has these 5 components: blood urea nitrogen more than 25 milligram per deciliter, impaired mental status, systemic inflammatory response syndrome that it was being discussed, if age is more than 60 years, and presence of pleural effusion. This is very, very important. If it is present, and then there is a scoring system based on the presence or absence of these variables. So what suggests a severe episode in the initial days, other than bicep score? So if you are doing, we all do CRP monitoring nowadays, and if his CRP at 48 hours is more than 150, it means this pancreatitis is going to be severe. If Apache scoring system is more than 8 at the admission, and it is increasing day by day, again, it is an indicator pointer toward the severity. And third, very important, is when after your full resuscitation, the hematocrit is not going down at 24 hours. After, as I said, these patients are usually lots of fluid loss in the third space, so that the hematocrit is high. But when you are adequately resuscitated, you have monitored the central venous pressure, you have monitored the IVC, and you are finding that hematocrit is not going down. It means it is going to have a severe acute pancreatitis. So very, very simple points we have to remember, and we have to monitor the patient. So as I said, lots of the scores are there. So Atlanta classification is just to see the different nomenclature, and which has a bearing in the management and outcome of the patient. Based on that, Ranson is important, Apache is important, bicep important, radiologic, which is most commonly used and very, very objective, other than biochemical, and which we can see in front of our eyes. But again, radiology is adjunct. Just based on the radiology, no decision is taken about the monitoring. So clinical, again, I'm repeating, clinical feature and clinical stability and clinical deterioration and the admission. These are three very important components of the management of severe acute pancreatitis. But as I said, CT will guide you how to go about that. And based on the CT scan, there is a Balthazar criteria and Balthazar grading system, A, B, C, D, E. And after that grading, there is a scoring has come. So 1, 2, 3, 4 numbers has been given based on the CT scan, extent of the necrosis, and then it has been said that what score is going to have a severe pancreatitis. So this is very important, and I think other than all biochemical parameters, CT is one of the very important factors. So I don't think it's I have to read everything, but everybody knows these are grading is given everywhere. So when you are doing, though there is you have diagnosed acute pancreatitis based on the clinical presentation and the criteria which has already been discussed most probably. Then if pancreas is normal on CT scan, then you can say that grade A. And if there is a focal or diffuse enlargement of the pancreas, and there is some irregularity and inhomogeneous in the contour, but there is no fluid collection, then it is a grade B. And if there is a pancreatic gland abnormality in grade B, as well as there is a peripancreatic little bit of inflammation, people say there is a mesentery is inflamed. So there are clear-cut features of the inflammation on CT scan. So I saw in one of the CT. So that is grade C. The moment there is a fluid collection, it becomes grade D. So if there is a single collection of the fluid, as it was shown in one of the pictures, then it is a grade C and grade C. And if there is a C plus 1, 2 or more than true fluid collection or gas in the pancreas and fluid adjacent to the pancreas, then it becomes grade E. And just to recapitulate what pictures I showed in the beginning, so you could see that these are the grade. You could see this is a peripancreatic inflammation I was discussing about, lots of inflammation and necrosis, and this is gas, and this is a single collection in the pancreas, and this is a contour is deformed here. Pancreas is enhancing here, but contour is deformed here in the head region, neck and head region, and there is a peripancreatic inflammation severe. So as the peripancreatic inflammation, however, there is no fluid collection, so it will be above the C. It is not going to be C or D. So this is very, very important to understand. So Balthazar criteria, that's why it is very, very routinely used. And later on, after this grading, they have gone to scoring system. So grade A has been assigned a score 0, and grade B has been assigned a score 1, and there is a less than 30% of the pancreatic necrosis. So you have to combine both. The pancreatic necrosis, as I show in one of the pictures, where is no fluid collection, that is very less than 30% necrosis. So that becomes grade B. There is no fluid collection. If there is a grade C, then assigned score is 2, and pancreatic necrosis is about 30 to 50%, meaning thereby either neck or head, it is not more than 50%. And this is assigned score is 4. And grade D, assigned score is 3. Pancreatic necrosis is more than 50%, and it is gets the score 6. So this is the highest score is 6, and grade E is a assigned score is 4. So this is very, very important for us to understand. Pancreatic is more than 50% this thing. So this just for the academic purposes. This is another model this scoring system in the modified CTSI, which has been after this Balthazar scoring, the CT severity scoring system. And here also almost same. There is nothing much difference. So the score is almost same. If you see, pancreatic inflammation is normal, intrinsic pancreatitis abnormality without inflammatory changes in the peripancreatic area. So peripancreatic changes are also very important. And then pancreatic and peripancreatic fluid collections and peripancreatic fat necrosis. However, there is no pancreatic necrosis that come in pancreatic inflammation. So intrapancreatic necrosis, meaning thereby the pancreatic parenchyma is not necrosed. But if there is necrosis, then either it be none, less than 30%, more than 30%. So I usually said that more than 30% is very, very important.
TD, sorry to interpret, but I think we are going over the same thing again and again. So I think we can wind up as fast as possible, because it's just a repetition of the various,
that's mortal score I was just, it is almost repetition. So mine is finished, because this was the last scoring system. So just to show the certain pictures that we can say that we can ask the agent based on this, what is the CTSI of
what is the scoring system that you use in your department regularly?
We are only using Balthazar system, because
Balthazar system.
We are not using. That's for the academic.
You are using Balthazar system.
Yeah.
Okay. So thank you for covering overall detail with very nice pictures. You have a wonderful collection of acute pancreatitis, as I can see.
Yeah.
So
just to say the resident that here is a gas, but a good CT scan is the most important thing for the to plan the management also. That's why I took up this picture for their benefit, that from where we have to go and how we plan our management.
Yeah. So any questions from the audience, from the PGs? In the box, I can't see the chat box. So
no, I will read them. Ramesh, I'll read them.
Yeah.
So one just to repeat a very important point which has been mentioned by both Dr. Rajen Desai and Dr. S.K. Mathur, that if there is any doubt, then an early CT scan, because bowel ischemia would be picked up only by that. And Dr. Arun Singh wants to know on IV fluid therapy in the first 72 hours to prevent necrosis.
Who's going to take that?
TD, can you take that?
Or shall I take that question? Can I take that answer?
Yes, Ramesh, please.
Yeah. So there has been a change in the way we look at the fluid management. Initially, it was, there were no guidelines. And then there were the guidelines that came, which said that the fluid should be given in a large amount, so that you have to replace a large amount of fluid. And the calculation was made where 100 ml per kilogram was given within 24 hours, first half in 8 hours, and then the next half in 16 hours. And to maintain a urine output of about 50 ml in an average size male of about 60 kilo, which means 1 ml per minute was this thing. But then in the last 5 years, there has been a significant change in the way the fluids are given, because people realize that patients who are given a large amount of fluids in the beginning started developing abdominal compartment syndromes in the later part of their pancreatitis. This was directly related to the fluid that was given. So the fluids that were given in the beginning moved out, and then they moved into the peritoneal cavity and other places, and they caused a lot of other problems. So today we tend to give fluids at a slightly lower rate, and what we tend to do is that we tend to lower the PCV by 5% in 24 hours. If you can achieve a lowering of PCV by 5% in 24 hours, which would mean that you produce about 50 ml of urine per hour with fluids, and you have to titrate this every 4 hours. So a patient has to be in a high dependency unit, has to have a nurse and a doctor who is preferably, in our centers, they are looked after by postgraduates in gastroenterology who look after the patient and make sure that they receive adequate fluids but not over fluids, and that their PCV index comes down. And that is something that is very, very important.
So, Dr. Ramesh, just one line about intra-abdominal pressure, and we did one thesis also. It's not only that it becomes pressure becomes high, the urine output goes down.
And that's what. Those are all the sequelae of IAP, rising IAP.
And again, we have seen people putting some tube or trying to put the tube, and it is exactly bowel edema. It's not that fluid is in the abdomen. It is lots of bowel edema, and by any means, it's very difficult other than opening the abdomen. If it is caused ACS, abdominal compartment syndrome, then we have sometimes we have put a Bogota, open the abdomen, make a laparostomy, just to decrease the bowel, this thing. And monitoring, I think we should put one line that you can monitor.
Yeah, it has to be a Foley's catheter connected to a pressure system, which will tell you the cystic pressure, which is a correlation of the abdominal pressure. But we found the Bogota bag that they invariably burst, they have infection there. So what we have started doing is that if we find it high, what we do is we do 2 relaxing incisions on the lateral walls of the abdomen, where we incise down to the sheath, rectus sheath, and leave the only the one layer of the abdominal wall intact. This itself will lower the intra-abdominal pressure significantly, because rather than opening the abdomen, this one, you divide the sheath laterally on both sides, and it makes the sheath actually moves out, and you can get quite a good amount of intra-abdominal pressure reduction.
Yeah, so the answer to Dr. Arun Singh's question, as has been mentioned by Dr. Ramesh, that from aggressive fluid resuscitation, giving liters of fluid in the early period, we have moved on to the general goal-directed fluid therapy, which is followed in any critically ill patient to maintain an adequate urine output so that you don't increase the intra-abdominal pressure to the limit of causing abdominal compartment syndrome, which then interferes with various other organ functions. So TD, maybe you can stop sharing so that I can put up Ramesh's slides.
Yeah. Dr. the next speaker?
Yes. Dr. Sastry, okay. Any comment before we move on to Dr. Ramesh's presentation?
Yeah, I think the point is made about the fluid management and the change in the perspective now from very aggressive to goal-directed fluid therapy, which I think every resident should know. What are the goals to be achieved in fluid therapy in various situations? When there is loss, when there is no loss. And that, I think it will be too much for us to mention the goals at this moment. You are advised to go back to your books and read about goal-directed fluid therapy. The other point I wanted to make about is the infection. Now, infection is something which is the main crucial game changer in acute pancreatitis, and it is most difficult to recognize when clinical sepsis signs are not present. If you have a high temperature and tachycardia and then high leukocytosis with in the background of necrosis, there is nothing. It's very simple. But you have a patient who is already an antibiotic. Most of them are referred to you with an antibiotic already, and a patient has an unsettled abdomen. These are the situations where one would like to know when to start an empirical antibiotic. Now here, mention is not made, but I don't know how many of you use procalcitonin. There is an important study by Srivardhana and the role of procalcitonin in deciding whether to give antibiotic, continue antibiotic, or discontinue antibiotic. I think it's a very important paper, and it's a very simple test, and it really helps in the, one is always hesitant to put a needle and introduce infection to prove infection. So short of that, we don't do that. But we definitely do a procalcitonin. It is more
we
than
also do
one
we also
nanogram.
would do a procalcitonin. And
Yeah.
I think most centers today, especially with critical care people looking after this, the procalcitonin has become very popular. So they use it routinely. Sometimes I think they use it a little too much. And sometimes, all this sort of pushes the cost of treatment enormously in a private setup. So it's a government setup, it doesn't matter. But in a private setup, you have to count every penny. And so I keep telling them, see, look, think of the patient not as a endless money back, but that he has limited funds. And do those. So what we have to teach our PGs, and this is relevant not only in acute pancreatitis, it is relevant in every disease that we treat. Before you do an investigation, think back. If this investigation comes as positive, what is going to be my management? If it comes as negative, what is it going to be my management? If the management is not going to change whether it's positive or negative, then you should not be doing that investigation. With this, you will eliminate a lot of unnecessary investigations.
Correct. So obviously we don't do procalcitonin in all the cases. You do it only when you have a strong suspicion of infection, but not overt. Say in such situations, and then when the patient is already on antibiotics, you want to stop the antibiotic. See, procalcitonin would be a good guide there.
Good evening. Yeah, so Dr. Chen Ko Hussein from Taiwan, who's coming for Amasikon, he knows me, so he just emailed me that there are some problems with visa if somebody from our end can help him. Yes.
So I think it's...
Yes.
Okay.
I spoke to Mr. Panda also, and I've told him, but I thought I'll inform you. I have told Devendra also to see if something can be done.
So I think
I am also trying to help
most of it.
some of my...
let's get on with the next. Dr. Kapoor, you're online. Okay, now he's muted. So, yeah, Dr. Ramesh. That is all I wanted to say about the infection and this one. So
I think we should move on because we made it a point that we start at 7 and finish at 9. So we are eating into Ramesh's presentation. So let me just introduce Ram, and then Ram can take over. Dr. Ram Daga again is my former fellow from SGPGI Lucknow. He is now the head of the Department of Surgical Gastroenterology at the prestigious Savai Man Singh Medical College in Jaipur. And Ram very kindly agreed to replace Anand as a speaker because Anand is busy with Kulbhushan, and Ram has agreed to my request to chair Ramesh's presentation. So Ram, maybe you can take over. Ram, up unmute kar lo. Yes.
Good evening, sir.
Good evening.
Good evening, respected teachers. I think we are already running short of time, so sir can start the session now. Sir, Ramesh, sir.
Yeah, thank you. So I'm going to speak on the step-up approach for necrotizing pancreatitis. There used to be a time when we were postgraduates, I think Vinay would remember, and when we had the occasional necrotizing pancreatitis, there was this huge operation. Patient would be on a ventilator for 2-3 weeks, and then ultimately, invariably, they would die, and very few would actually walk out alive, and those who did, it was considered a miracle. But then we have changed in so many ways. I think what has contributed to the improvement in the management is our understanding of the early fluid balances, which has improved now with that fact that we don't give over fluid, but curtail the fluid and make sure that we balance the requirement between sufficient fluid and over fluid. The second is that the intensive care who have now contributed by their methods of ventilation, like non-invasive ventilation, high nasal flow cannula ventilation, NIV ventilation, and using endotracheal tube as a last resort rather than as a first resort, which used to often cause a lot of respiratory infections. Then we have got the appropriate use of antibiotics, and we now know that certain antibiotics are good in acute pancreatitis, and when we require, we use them in the appropriate concentration, and that seems to have improve the outcome of these patients, and of course our times of intervention. Now we know that necrosis is associated with a high mortality rate, and this is what is called as critical pancreatitis. And in the very early phase, on the first 2-3 days, a certain number of patients will die, and there is very little that anybody, including critical care, gastroenterologists, surgeons, can do to salvage these patients. These patients have respiratory problems, renal problems, cardiac problems, and they have very distended abdomen. They have rapid multiple organ failure, and they rapidly succumb to the disease. And even today, we have not managed to have an answer to what can be done for this early mortality that occurs within 72 to 96 hours. We can only hope that we can tide them through this time by giving them appropriate fluids, appropriate antibiotics, and taking them to the next phase. As we already said, to remember that acute necrotic corrections are less than 4 weeks, WOPN is more than 4 weeks. And we want to delay any planned intervention for necrosis. We used to say that we should delay it by about 21 days. Initially, it used to be that when you have acute pancreatitis, you go in, you open the abdomen, you try to take out the necrosum, and all these patients would die. But then we decided to postpone this to 21 days to 28 days, which is what I was taught when I was an MS postgraduate and when I was an MCH postgraduate. And in that, we had a little more salvage, but we still had a lot of complications, a lot of problems. So then as we started practicing, as I came to Madurai, and along with others in various pancreatic centers like H. Ramesh, VK Kapoor, Sanjay Gandhi, others down in Medanta, we all got onto the same bandwagon. And that is, you delay the intervention as far as possible to say, in an average, our intervention days have now increased to about 44 days. So from 21 days, it has gone almost double to 44 days, and the results have appropriately improved. How do we intervene is guided a lot by the clinical picture, the availability of equipment, and the local expertise and the investigations which are locally. Now, many hospitals don't have an in-house CT. So they have to shift the patient somewhere for a CT scan, and this patient may be on an NIV or on a ventilation. To shift him and shift back causes severe physiological changes, and the patient may actually deteriorate because of that. So I believe that the ideal patient of severe acute pancreatitis should be managed at a tertiary center which has availability of critical care, surgical gastroenterologists, medical gastroenterologists, and interventional radiologists. So you have all 4 arms of treatment available. You should have a CT, if possible an MRI, but MRI is not so essential in acute pancreatitis as a readily available CT scan, where you can just wheel the patient to a CT scan and come back and do whatever investigations are required. And the fact that you should have a critical care unit where you can do all sorts of ventilation, central line management, arterial line management, intra-abdominal pressure measuring, and you must have a constant discussion between these 4 groups of patients, doctors, because every doctor has his own ego and he thinks that his treatment is the best. But we now have the idea that, yeah, there are people who know something more about critical care than I do. I know a little bit more about interventions and surgery than a radiologist does, but a radiologist can do the intervention more successfully than I can do because I cannot do it. So we have to look at the expertise, and we have to form sort of a team approach and manage these patients with a much. So all these patients should be seen daily by everybody, so that you have a multi-approach, and then somebody may give a pointer that today we will do this or tomorrow we will do this. You must also remember that in acute pancreatitis, there will be a severe nutritional loss. So you have to provide nutrition for these patients. They have severe pain, so pain relief has to be given and complications have to be managed. So we avoid surgical intervention in the early, we avoid it in the first 8 weeks actually, up to 35, 40 days, we don't even operate. So what do we do then? Then what we do is that we use radiology as our strong arm. So in the earlier phase, whenever there's a collection, you see, and that is causing the patient having fever, total count is going up, patient looking toxic, we put in a pigtail into that collection and drain it out. And then when you drain the pigtail, it's not just one time. You have to see that the patient sometimes will become more sick after 2 weeks or 1 week after putting the pigtail, because the collection has become thick and the collection is not coming through that 14 gauge tube that you put. Now you have to upsize the tube to a 16. So the radiologist has to be brought back and told, upsize it to a 16 size tube. And then you can irrigate through that and get all this dirty muck outside. And the antibiotics. First, we do presumptive antibiotics, which are good in acute pancreatitis. For example, we would use imipenem-cilastatin or meropenem in the first phase. But then once we have started getting cultures, we would use the cultures to guide us to the appropriate antibiotic and get the infection control the doctors also into the picture and ask them, you can suggest some a combination of antibiotics based on your cultures, which are not fully sensitive, but the combination may be adequately sensitive. So this is something that is new. That is, the infection control tells you that A antibiotic is partially effective, B antibiotic is partially effective, but when you combine A and B in this case, you may get a very good response. So do that. So we should use their expertise because they are reading about it daily and they can give you some good inputs into these things. Then we can use the CT scan regularly whenever we have a problem. And way to save the cost is that we do a CT screening. We just do a CT on the monitor. We don't take pictures, and we just ask the radiologist to show us the pictures on the monitor, and then we manage with that. So with that, the cost is less than 1/3 of what it would otherwise cost for a full-blown CT. But suppose you want to do an intervention, then you need a full-blown CT because you want to look for pseudoaneurysms, you want to look for collections, you want to look for vascular bleeding, you want to look for all those things, and then we will look at it. And we have seen that once you start doing this drainage of fluid, which is the first part of the step-up approach, the patient's fever comes down, he starts to eat, and he feels better, he improves somewhat. He may then again deteriorate, and when he deteriorates, then what we do is that we do the guided drainage. That we look at a CT now before the drainage, and we sit with that and look at the tubes that we have put in, and we use one of these tubes by dilating the tract, and we use a large cannula, a 13 millimeter cannula through that. And through that, we use a 5 mm and a 5 mm suction with a 5 mm telescope. We use both through the 13 mm, and we go in and we wash and remove as much. We go as far as possible to the other side, down. And if necessary, on the other side also, we open up the size to 13 and again do the cleaning. And we try to link up the two sides. This is very important. If we can link up the two sides without damaging the vessels, very important that vessels are stretching across the field. So you have to be very careful and gentle. Use a lot of hydrostatic dissection with your fluid under pressure, and you don't damage the vessel. Or you see a large vessel crossing and you think it may be splenic or something, then you clip that deliberately so that it doesn't bleed later. So you clip it deliberately so that it doesn't bleed at a later stage. And once we have done that, what we do is we leave tubes on both sides and we irrigate from one side and at 100 ml per hour in the first day. And the necrosome will keep washing out the entire retroperitoneum, and all the dirt will come out on the other side. The next day we switch from irrigating to the opposite side and letting it come out from this side. This sort of alternate drainage and this irrigation leads to a good clearing of the retroperitoneal, and you find a dramatic fall in the temperature, the patient improves. And you have to keep looking that the fluid doesn't start showing any signs of blood. This is the most dangerous thing. Nowadays, we don't lose patients to sepsis. Patients don't stay on ventilator long, maximum for a couple of days, and then they are off the ventilator. They die is of bleeding. They are 1 minute fine, and then next minute they have torrential hemorrhage in both the drain, and within 1 minute we have lost the patient. So this is the only this is the common way of death today that we see in acute pancreatitis. And every year we do about 20 minimal access interventions, 15 to 20, and about 2 or 3 patients we lose due to this bleeding. But this is 2 out of 3 who die out of a total cohort of about 300 who actually present to us. We have about 1 case every day new of acute pancreatitis out of 300 patients. We ultimately end up losing about 3 or 4 in the early period, for which there's nothing we can do. And then we end up losing these 2 or 3 who do die due to sudden bleeding from massive vessels. But of recent past, this bleeding has also decreased because we have understood that we can proactively clamp the vessels with clips and stop the bleeding, and that if bleeding starts when we see the when we are doing the lavage, what we do is we come out, packing the area, wait for 48 hours, and then go in and unpack, and by which time most of the bleeding has stopped. There are people who would do video-assisted retroperitoneal debridement. They will put a big stent into the retroperitoneum and then 2 days later do a little debridement. But this usually requires 4 to 5 sittings of debridement. And if there is a bleeding which is massive at this stage, it is almost impossible to control. You have to rush to the theater, and by that time you may lose the patient. On the other hand, when we are in the theater, and we can just pack it and come out and prevent the thing. And I have noticed that in the last 20 years, the enthusiasm among medical gastroenterologists to do video debridement with all that smelly pancreatic material coming out and that rotten, everything gets contaminated, they don't like it, and they have just handed it back to the surgeons now. So there are a few dedicated people like Todd Barron and all who continue to try to do this procedure, but otherwise everybody has handed it back to the surgeon and say, you take care of it, this is muck, we don't want to try. The necrosectomy can be done by open also, but by and large, open necrosectomy seems to be very much going down because of the large morbidity. They sometimes require long-term ventilation, and they don't do very well in the long term. With open necrosectomy, there are benefits. You have better visualization, you have better hemorrhage control, and you can just finish with one intervention. But the problem is that the patient may go on a ventilator for a long time and may have a massive wound which will take a long time to heal, and then it will form an incisional hernia which has to be repaired at a later date. Laparoscopy avoids all this. It avoids the inflammatory response. It decreases the hernia risk, and you have access to the entire abdomen. You can do high speed irrigation and remove all the things. So the minimal invasive therapeutic option has been designed where the New Zealand group has said it is a VRP classification: visualization, route, which could be percutaneous, transperitoneal, and purpose: drainage, lavage, or debridement. And so the percutaneous catheter drainage has really revolutionized the management of pancreatitis by giving us this intermediate option. So from managing the patient's fluid and antibiotics to a major surgery, we have this intermediate option where we can put in multiple pigtails. Sometimes we have got as many as 3, 4, 5 pigtails in a patient. And I used to say that these patients look like Bhishma. They, on the day when he's lying, with all the arrows sticking out of him in the battlefield, they have so many tubes. But sometimes these patients never require a surgery. With multiple tubes, irrigation, they settle down, and then you can remove the tubes one by one, and they'll go home without a single operation. We have got quite a few of these patients. And the Panther trial, of course, all of you know, which was the first one to advocate the time up. But I must say, to our credit, we had done this 10 years before the Panther trial. We had started doing minimal access necrosectomy, putting pigtails and not operating and delaying it to 42 days. And our results had improved. And so we did not find that this trial was a surprise, because we expected these results, because we have been practicing this for many years prior to I did my first minimal access necrosectomy in the year 1999. So you can see that we have done it for 25 years, and this trial was started in 2010 and then reported. So we had already been doing this, and we had found very good results with much better things. And as you can see, when you look at endoscopic drainage with surgical necrosectomy, in open surgery, there's an 80% mortality. And so it is not a good mortality or a complication. So open surgery early is certainly out, late, avoid it, try to do by minimal access. The Liverpool also believes that minimal access gives better with mortality odds risk reduction by 73%. You have the tension trial, and there they found that if you use the step-up approach, there's a hospital stay is reduced by 16 days, and pancreatic fistula is reduced dramatically. And new onset cardiovascular failure and persistent cardiovascular failure is also reduced. Then you have the MISER trial, which shows endoscopy versus minimal access, and here they found that the endoscopic had a slightly better than the minimal access. So they had advocated the endoscopic, but as I said, the endoscopic takes multiple sittings, is expensive, is difficult to perform, and so most people have gone on to the minimal access and not the open surgery. The open surgery, I can see, has significantly so this is the algorithm that can be followed. You have suspected necrotizing pancreatitis, you temporize with antibiotics, they may resolve and no more treatment. Rare patient may go for laparotomy because there's a viscous perforation or there's an abdominal compartment syndrome. There's ongoing sepsis, percutaneous drainage or endoscopic drainage, one of the two. Percutaneous is what we prefer because endoscopic means you're pumping gas into the abdomen, the bowel becomes bigger, the patient is immediately sicker after the endoscopic procedure. So we prefer the percutaneous with the radiologists. They do that, and if they can control the infection resolution, no more treatment. If there's ongoing sepsis, then we can do re-intervention, putting percutaneous drainage, accompanied by maybe endoscopic drainage. Or we can do video-assisted retroperitoneal drainage, endoscopic debridement, and minimal access debridement, which may lead to resolution. There's ongoing infection, we usually repeat the ward and endoscopic debridement, and they settle down. With this, we now, out of 300 patients who come to us with all stages of acute pancreatitis, we do these percutaneous interventions in about 100 of these patients, approximately. We do the minimal access drainage through these ports in about 15 or 20 in a year. And in only 4 or 5, we would go on to actually an open or a more major debridement because the endoscopy can't reach everywhere. Of those 4 or 5, we lose 1 or 2 to bleeding. We don't seem to lose the others to bleeding. It's only from this last bit of open group. And so the mortality is this 2 or 3 in the last group, and the 2 or 3 in the beginning who come with acute renal failure, cardiac shock, ARDS, and who never cross 2 or 3 days in the ICU and die. So the day has come that acute pancreatitis has to be managed by minimal access techniques, has to be managed by a step-up approach where you judicially use antibiotics. Everything is done to postpone the intervention as far as possible. This is the aim. You postpone the final major intervention as far as possible. By that time, the tissues that have died, the necrotic tissues, have stabilized, and they will come out easily with just irrigation and teasing, and the bleeding becomes significantly less, and the patients do well. Thank you very much.
Ram.
Yes, sir. Thank you, sir, for summarizing it in such a concise way. Now we all know that things have from aggressive open surgical approach. Now things have changes to, for management of pancreatitis, things have changes to step-up approach. Just a minute.
So, Dr. Sastry, maybe you can
Yeah.
Yes, sir. So,
yeah, I
we
think
have
we're
moved
running
to
out
now
of
step
time.
up
I
approach.
just want to summarize. Just take the pearls of again what Dr. Ramesh was saying. The step-up approach. What are the basic principle? The basic principle is to reduce the sepsis load by time and with the least disturbance to the complicated physiology that is happening. See, these are the basic three principles, and added to that, it's not always necessary to remove the entire necrosis. And say that is it's impossible to achieve. That's overambitious. So taking that as an advantage, we distribute the risk over a period of time, assuming that sometimes even with the first intervention, that may be enough. You may not need to go to the next intervention at all. I think that is the basic principle of the step-up approach, and that has come to stay. There is absolutely no criticism so far about the step-up approach, and that has saved a lot of lives. It's very important to remember the principles. How it is executed would depend totally on the local resources and your own expertise. I think this is all the comment I wanted to make. It's time, Dr. Vinay.
Yeah, Ram, anything?
Sir, only thing that we still don't know what are the endpoints of this conservative management. When we have to change from this conservative treatment from percutaneous strains from laparoscopic approach to open approach. What is the endpoint? We still don't know. We are losing a subset of patients with this step-up approach still, because we still don't know when we have to convert to open surgery or when
we have sort of found that we very rare, I mean, the conversion to open surgery is extremely rare. We use the safe ports, or we find other ports. Once we find a collection, we place the ports and then we enlarge the openings. And so we don't even use the standard, transperitoneal or ward to do that. We use the percutaneously placed catheters. We put a guide wire through that, and then we use the Amplatz dilator from the radiologist, and then we put in a 13 mm port through that, and then through that we put one cannula with which we can suck or thing, and a 5 mm telescope. So use a 5 mm telescope and through one port. So this is what is our routine, and we rarely now really do a full open necrosectomy unless we find when we have gone in that this necrosectomy is sitting on a very major artery and we are unable to clear the artery. Every time we touch it, there is a little bleeding. Then we say, okay, today we have to open this and clean, because this artery, if it explodes in the minimal axis, is going to be death within 1 minute. So there we abandon. So this, as I said, in a year, maybe once or twice we abandon this. And some of these patients are the ones who bleed later on also.
Sir, may I know the experience of other people in the house? Sastry sir, Kapoor sir, how many actually you have to convert to open in your practice?
Again, as Dr. Ramesh is saying, it's not necessary to convert to open. It all depends on, see, it's such a varied picture. If you have multiple locations, necrosis in multiple locations, and it's not possible to achieve, through 1 or 2 laparoscopic ports, definitely you would like to convert, and the patient has clinical sepsis, a deteriorating situation in spite of the first 2 steps. So that would be the indication. How to identify that step is basically a patient who is not improving or he is worsening. See, the absolute criteria are basically of sepsis. Same of the patient is improving it, he starts accepting feeds, he doesn't run temperature, and his leukocytes is coming down. All those features you would be monitoring. It is those ultimately the clinical pointers which would decide in favor of changing your approach from percutaneous to endoscopic or laparoscopic or open. You have to take multiple points into account. It cannot be condensed to 1 or 2 points.
So the only other situation I would say where probably you may prefer an open approach is that if you have a doubt about the colonic involvement or viability and you are thinking of creating a ileostomy, because If the ileum is very thickened, very edematous, it may be very difficult to handle it laparoscopically. And then I would prefer to hold it with my finger rather than with an instrument.
Completely agree with Vinay. What we do is, in this situation, we put in drains and start the irrigation. When we start seeing the motion coming, then we do a contrast enema of the colon on the CT scan with a retrograde contrast, and we see a little leak. We know now that we have a colonic fistula. Then what we do is we make a small opening on the right iliac fossa, bring out the ileum and make it as a loop ileostomy and divert the motion. And remember, when you patient has become perfectly all right, don't just close the ileostomy, because the colon that is in the necrosis would have become fibrotic and it will not work. So you have to do a subtotal colectomy and then bring the ileum to the descending colon or to the sigmoid, and then do the anastomosis there to a well-vascularized segment. And you should remove this one which is in the caught in the pancreatic necrosis.
Yeah, just a word of caution for all, especially young colleagues, that it sometimes may be very, very difficult to handle the jejunum for a jejunostomy and ileum for an ileostomy. And they have to be handled very gently, it may sometimes be very difficult to bring a loop of ileum out, especially if the patient is a little obese. So we are at 9. I think we will close. As I said, we would like to start at 7 and close at 9. So I would like to thank Dr. Sastry for agreeing to moderate, all the speakers, all the chairpersons. These are some announcements. Those of you who do not know about Jaipur Surgical Tutorial, this is every Saturday morning 9 to 10 academic activity. If you want to join, please send a WhatsApp message to my colleague, Dr. Anand Nagar, who manages the Jaipur Surgical Tutorial. That's his number. And we have started another activity because colleagues from Africa, they were not able to join Jaipur Surgical Tutorial. It's very early morning for them. So primarily for them, we've started a Jaipur Surgical School Friday afternoon. This is being managed by my colleague, Dr. Kailash Kurdia. So please send a WhatsApp message to him if you want to join. So once again, thank you everyone. And we meet at the same time tomorrow, 7 p.m.
Thank you. Very nice session. It's been a pleasure.
Thank you. And special thanks to Kulbhushan for agreeing to chip in at the last minute to replace Anand. Anand was busy today. And okay, bye. Good night.
Bye. Bye. Thank you, sir.
Thank you. Thank you, Himanshi. Thank you.
Thank you so much, sir. Good night.